All right, good morning, everyone. So I'll be talking about hematuria this morning. And first, we'll talk about some current guidelines in hematuria workup, go through the imaging technique, and show you lots of cases on different reasons for hematuria. Hematuria is a very common indication for imaging of the urinary tract. It can cause both microhematuria or gross hematuria. And the pathology can arise anywhere along the urinary tract, involving both nephrogenic and urogenic causes. Some common causes for hematuria include renal parenchymal disease, urothiasis, infection, BPH, trauma or vascular etiologies, papillary necrosis, and importantly, malignancy. Renal parenchymal disease doesn't really have that many specific imaging findings, so I'm not going to talk about that, but then I'll talk about all the other entities. Thinking about the clinical workup for hematuria, we differentiate it into microscopic and macroscopic hematuria. Microscopic hematuria is defined as 3 or more red blood cells per high power field on UA. And first, clinically, the clinician would exclude any obvious benign cause for hematuria, such as recent infection, menstruation, trauma, etc. And then if they don't really have an obvious cause, then they risk stratify the patient based on risk factors for malignancy. If the patient is considered low risk, then they would repeat the UA in 6 months or perform a cystoscopy or renal ultrasound. Intermediate risk patients would go right away to cystoscopy or renal ultrasound. If patient is considered high risk, then they would get cystoscopy and either CT or MR urogram for further evaluation. With gross hematuria, there is actually visible blood in the urine. It can go either from kind of a dark orange, brown tinge to actually frank blood. And they are much more concerned with gross hematuria because the risk of malignancy associated with gross hematuria is much higher than for microscopic hematuria. So therefore, the patient will undergo either cystoscopy or CT/MR urogram right away. What about the ACR guidelines? So if a patient is coming in with microhematuria, again, they need to be worked up for the common benign causes. And if there's a benign cause that's explaining the microhematuria and the patient doesn't really have risk factors, you could conceivably not do any imaging. But usually the imaging that's done would be a stone study, CT abdomen pelvis without IV contrast. And if patient has some risk factors, then we treat this more seriously. And the exam that's most recommended would be a CT urogram with or without IV contrast. The other exams on the list are MR urogram and other CT scans. So in the ACR guidelines, they specify the urogram as opposed to the other CTs because they specifically want to include the excretory phase images. And another variation is microhematuria in a pregnant patient. These patients are generally younger, have low risk for malignancy, and we also want to avoid radiation. So the recommended test is an ultrasound, followed by MR urogram without contrast because we don't want to give a pregnant patient any contrast. For a patient coming in with gross hematuria, in concordance with the urology guidelines, we are recommending a CT or MR urogram with or without contrast. Those are the best tests, and you have other options as well. In terms of the CT urography protocol, ours is a 4-phase protocol with non-contrast, arterial, venous, and delayed phase images. Our arterial and delayed images goes all the way from the kidneys to the level of the bladder. And it's a very nice comprehensive evaluation, one-stop shop, that can catch most of the etiologies that will cause hematuria. Very high sensitivity and specificity for catching malignancy also. And because MR urography is on the list of recommended tests, I'll show you what it looks like, even though it usually doesn't apply in the ER setting. So we rely heavily on T2-weighted images in both axial and coronal. And importantly, we have the static fluid MRU, which are these very heavily T2-weighted images analogous to the MRCP. So what you're trying to use is the urine as the intrinsic contrast agent, and then you're looking for any filling defects. The advantage of MRU is you can potentially do it without contrast in patients with contraindications. First, let's talk about stones. So stones are very common, and it affects 1.2 million of Americans annually, affects 14% of men and 6% of women during their lifetime. Very high risk of recurrence, because once you have stones, you tend to have more stones, with the recurrence rates of 50% within 5 to 10 years and 75% within 20 years. And CT is really the gold standard for evaluation of urinary stones. And these stone studies are very common. They account for 22% of CTs performed for acute abdominal pain in the ED, and 55% of patients undergoing the CT for these acute flank pain did not have stone disease. 15% had other abnormalities detected. But overall, these stone studies are very helpful in altering clinical management in nearly 60% of patients suspected of acute renal colic, both in identifying the other pathologies and in identifying complications related to the stone disease. The stones come in different flavors. The most common type would be calcium-based stones, which account for up to 60%. They are radiopaque with the Hounsfield units more than 1,000, and there may or may not be any underlying calcium metabolism disorder. Uric acid stones are classically radiolucent on KUB, but on CT they will still look dense. So all the stones we can see are actually dense on CT. And then you get into other varieties like struvite stones that are usually associated with chronic renal infection. And if you want to get really fancy, you can do dual energy CT to do the stone composition analysis. Our clinicians haven't really asked us to do that, so that's not something that we do on a clinical routine basis. With stone disease, the clinical symptoms are usually flank pain, voiding urgency. They may come in a gross or microscopic hematuria, nausea, and vomiting. The usual workup would include a CBC, a UA, and a BMP, and the 24-hour urine collection is usually only reserved for patients with recurrent stones and not the first-timers. When we look at stones, it seems like such a basic thing, but I think there are still some pearls in the evaluation of stone disease. So here I'm showing the same case, but on 3 millimeter and 0.75 millimeter slices. With these small stones, with the 3 millimeter thick slices, you can easily walk by it. It's a very small little speck in the kidney. But the same stone on the 0.75 slices, because you're getting rid of a lot of the volume averaging effect, looks much more obvious. So you're much less likely to miss the stones if you double check on the thin slices. Similarly, on the coronal view, I also find it very helpful in looking at these tiny stones that sometimes it is just hard on the thicker slices and on the axial, but it look a lot more obvious on the thin coronal slices. And when we see these patients coming in with flank pain, they often also have a lot of calcifications in the pelvis that it can be tricky to differentiate stone in the distal ureter near the UVJ versus the pelvic phleboliths. So carefully looking at thins and on the axial helps. I also like looking at things on the coronal because I find it easier to trace part of the ureter. And in this case, it's also helpful that you can see the asymmetric enhancement of the two kidneys showing some delayed clearance of contrast on the left. So clearly the calcification on the left is a stone in the distal left ureter versus this one is actually just a pelvic phlebolith. And we can also see stones on ultrasound, obviously. And then you can see here that there's an echogenic focus on the kidney. And then our usual protocol, we look for jets, and bilateral jets were present. But there is mild hydro. So are we done here? Should we do anything else? So for us, if we see that there's hydro, unless we can really see the ureter following all the way down to the bladder, you have to look for a cause for something that's obstructing and causing the hydro. So we recommended a CT, and lo and behold, we do see the tiny non-obstructing stones in the kidney, but also this stone that is in the ureter that's causing obstruction. So I would say in a patient with stone disease, when you see hydro on the ultrasound, you should do something else to look for these stones that may have passed into the ureter that's causing obstruction. Stones, you can also get staghorn calculus. This is a rather large stone in the renal pelvis with posterior shadowing, and you can see the obstruction on the ultrasound. Similarly, on the CT, you have the stone that's involving the renal pelvis and also the calyces. This is a very pretty example of staghorn calculus in which you have this huge stone that's basically involving the whole renal collecting system, descending all the calyces and also the renal pelvis. You can also get stones in the bladder. These account for 5% of all urinary tract stones. They can be primary, and they form in the absence of other urinary tract abnormalities. They're usually found in patients in developing countries, thought to be due to poor hydration status or nutritional status. They can be secondary in patients who have urinary stasis, or can be migratory with the renal calculi that migrated down into the bladder. Here's some example of some bladder calculi in which you can see these dense stones that are sitting in the bladder. And then on the delayed phase, you can see there's some contrast making it into the bladder, outlining some additional filling defects, which are some blood products that was why the patient presented. Next, we'll talk about urinary tract infection. This is usually a clinical diagnosis, but imaging has its role in patients who are coming in with an unclear clinical presentation. We can also assess causative or contributory factors for complicated UTI, and to evaluate treatment response in the patients who are not responding. Here's just an example of cystitis, in which we can identify a thickened bladder wall. There is some stranding around the kidney. Because cystitis, I think sometimes is easy to overcall it, because in an undistended bladder, the bladder wall is going to look thick. So you really have to consider is how well the bladder is distended before calling bladder wall thickening. In this case, we also see additional debris in the bladder that clinically they had cystitis. And when we think about infection traveling up, it can also involve the kidney. So pyelonephritis, we classically see ill-defined wedge-shaped areas of low attenuation, decreased corticomedullary differentiation with a striated nephrogram. From a technical standpoint, these findings are best seen on the venous and delayed phase images. So on a routine stone study that's done without contrast, you can easily miss early pyelo because you're not going to appreciate that. And even on the arterial phase, can be very hard to appreciate. And we can also look for complications such as renal abscess or tissue necrosis. Here's some very florid example of pyelonephritis in which both kidneys are abnormally enlarged, the left worse than the right, and we have these striated or wedge-shaped hypoattenuation along the periphery of both kidneys, consistent with some tissue necrosis in a very bad case of pyelo. Just to show you the MR appearance of the same case, we have these wedge-shaped T2 hyperintense non-enhancing areas with the pyelo and also superimposed tissue necrosis. Pyelonephritis, there are also different forms, including xanthogranulomatous pyelonephritis, which is an atypical immune response to chronic infection caused by long-standing obstruction, usually by those staghorn calculi. This leads to progressive destruction and replacement of the renal parenchyma by lipid-laden macrophages. Classically, we see an enlarged kidney with low attenuation rounded areas, and XGP may involve the perirenal and pararenal spaces. This is a pretty classic example of XGP in which we see the staghorn calculi in both kidneys, and then this abnormal low density areas within the kidney which are replaced with those lipid-laden macrophages. Another complication of pyelonephritis is emphysematous pyelonephritis. It's a necrotizing infection that can involve either the renal parenchyma and or the perirenal soft tissues. Risk factors include diabetes and immunocompromise. And emphysematous pyelonephritis comes in two types, with type 1 involving intraparenchymal gas and necrosis but no fluid collection. Type 2, we see more collections and less necrosis. This is an example of emphysematous pyelonephritis in which we see this gas collection that's within the kidney, so pretty easy diagnosis. This is another case of emphysematous cystitis in which we can see the abnormal gas that's tracking along the bladder wall. It's important to mention that we frequently see gas along the antidependent portion of the bladder in patients who have recent instrumentation or indwelling Foley. The emphysematous cystitis, we want to look for gas that's going all the way around the wall, not just the normal gas that we would expect. BPH, we don't often think about it in the assessment of hematuria, but it can also cause bleeding because those cellular proliferation in BPH is associated with increased vascularity, and these new vessels are fragile and can bleed. However, because BPH is so common, just because a patient has BPH, that should not dissuade the clinician from further working up the hematuria. The treatment for BPH is with finasteride to shrink down the BPH nodules. This is a patient who came with hematuria, and the cause turned out to be severe BPH. On CT, it can be difficult to resolve the soft tissues to differentiate this big mass. Is it a bladder mass? Is it a BPH? And looking at different planes certainly can help, but also ultrasound and MRI can be very helpful in that distinction. But this other patient, they came in with hematuria, and we can see this filling defect within the bladder. And then we put color on it, there's flow. So what is this vascular bladder mass? And then we went on and did a 4-phase study in which on the non-con you can appreciate there's some filling defect, there's some intrinsically bright stuff, that's the blood. And then we can see on the delayed phase, there is that thing, and then also the other stuff on the side, that's the blood products. And the mass is enhancing, so your differential would be, is it some kind of bladder tumor or BPH? So when we look at it on different planes, we can see that it's contiguous with the prostate, and this is a case of severe BPH causing bleeding. We also need to consider renal vascular injury and trauma in the assessment of hematuria. So perinephric hematoma, pseudoaneurysm, dissection or transection, arterial venous fistula, you can have a whole host of these different renal vascular injuries. In the trauma literature, it's separated into 5 grades. Grade 1 and 2 do not involve the renal vasculature. Grade 3, the injury is confined within the perirenal fascia. Grade 4s and 5s, you have more injury to the renal artery, and it's more severe, so grade 4s and 5s usually will require some kind of operative management, whereas 1s and 2s usually are managed conservatively. So this is a trauma case in which the patient obviously has a renal laceration with a perinephric hematoma. And on the delayed phase, you can appreciate the filling defect within the renal collecting system. So I read it with a trainee, and the trainee said, okay, it's a grade 2 renal laceration with a hematoma, done. But then when I went through it with him, it's like, well, look at this renal artery. It looks a little bit irregular. So we have to look very carefully at these subtle injuries. So when we look at the coronal and on the MIPS, you can appreciate that there is this abnormal contrast collection along the renal artery, and these are multiple renal artery pseudoaneurysms. So patient went to IR and they embolized it. So that subtle finding changed someone from a conservative management to now going to IR. And with these subtle renal vascular injuries, SINs will help, MIPS, coronals, and use all those 3D techniques will help bring it out. This is a different type of trauma. Patient recently had a renal biopsy that you can still see that there's some blood products within the pararenal space. And we're seeing this abnormal blush of contrast along the lower pole. And again, MIPS help to bring out these kind of vascular injuries in which we can see this dilated renal artery taking this turn and then it going up and draining into the renal vein. The corresponding image from the angio showing this AV fistula with the dilated renal artery and the early draining vein. You can also get non-traumatic vascular etiologies, such as nutcracker syndrome. It is a renal venous compression syndrome caused by ruptured thin-walled venous collaterals into the collecting system. More common in women in the second to third decades of life. Patients may present with hematuria or flank pain. And what we see on imaging is a narrow angle between the aorta and the SMA and the beak sign. So here is a patient who presented with nutcracker syndrome in which we can see the left renal vein coming across and it's being squished between the aorta and the SMA. And on the sagittal, we can see a very tight angle with the takeoff of the SMA and the crossing left renal vein. And you can also have collecting system abnormalities that can cause hematuria. So with papillary necrosis is caused by impaired vascular supply, causing diffuse ischemic necrosis of the renal pyramid distal segments. There are a bunch of risk factors including diabetes, analgesic overuse, and sickle cell disease. The classic CTU findings are ball on a T, lobster claw, and calyx seal blunting. With the papillary necrosis, the findings can be a little bit subtle. So on your excretory phase images, you may have to play around with the windowing a little bit so you can appreciate the subtle details. Here we can see that there is a golf ball sitting on a tee. And then on some of the other calyces, we can also appreciate some calyx seal blunting. And putting it on the 3D rendering MIPS and VRT can also help bring out these kind of very subtle morphologic findings in papillary necrosis. But ultimately, the recommendation to do CTU and MRU are to look for malignancy. So there are several risk factors for malignancy, including male gender, age, history of smoking, some toxin exposure, and chronic indwelling foreign body. From a clinical perspective, if they come in with gross hematuria, irritative voiding symptoms, and chronic UTI, that will also increase the risk. So here is a patient who came in with gross hematuria. So on the non-con, you can already appreciate the bright hyperdense blood that's sitting in the renal collecting system. And after we gave contrast, we can appreciate the diffuse heterogeneous enhancement of the kidney on both the arterial and venous phase with a diffusely infiltrative tumor that's basically replaced the entire kidney. This is a different case in which patient presented with a subcapsular hematoma, as you can see in that hyperdense crescent around the kidney. And whenever a patient comes in with a spontaneous renal bleed, you really have to be concerned about an underlying tumor. And in this case, we can see that there's a heterogeneously enhancing mass right here medially. And this was a case of renal cell carcinoma with a spontaneous subcapsular bleed. Urothelial carcinoma can also bleed, and it can arise anywhere in the urothelium, going from the renal pelvis down the ureters to the bladder. In the kidney, we usually see an infiltrative mass with obliteration of the renal sinus fat, also known as a faceless kidney. We can see subtle enhancing filling defects or thickening within the collecting system. And once we find one, we should really very carefully scrutinize the entire collecting system due to the high prevalence of secondary foci of tumor. Here are some examples of urothelial carcinoma. You can see it on the non-con and expansile mass, but obviously better seen on the post-contrast images. But even better seen is on the excretory phase, in which the urine is very bright, and then you can see the filling defect right there. This is a much more subtle case that I like to show why the excretory phase is so important. For the eagle eye in the audience, they may be able to appreciate some subtle fullness in the renal pelvis, but it's really hard. But on the excretory phase, it makes it so much more obvious when the urine is so bright, and then you have this abnormal filling defect in the renal pelvis. Just showing you the corresponding image from the CTU and also on the retrograde ureterogram. This is another case with the heterogeneously enhancing mass that's enlarging the renal pelvis and extending into the kidney. And the reason I want to show this is to show the corresponding MRU. So on the MRU, the T2-weighted images, the urine is bright, and then you're looking for these filling defects on the MRU. And this is the post-GAD images on the excretory phase, and then similarly, you can see the filling defects. This is a case in the distal ureter in which you see this abnormal bulbous thickening of the distal ureter. And also another clue is that this right kidney is asymmetrically shrunken and there's some hydro. So whenever we see hydro, again, we got to look for a cause. And then on the MRU, later on, the hydro has worsened with more atrophy of the kidney with this mass in the distal ureter. I'll finish up the discussion with bladder cancer. We have a whole bladder talk in the GU section on Wednesday. But basically, urothelial carcinoma accounts for most of the bladder cancers. Usually, they avidly enhance, they will restrict. They can be seen as a polypoid mass or some asymmetric bladder wall thickening. And we usually think of them as filling defect on the delayed phase. This is an example of a muscle-invasive bladder cancer in which we have this irregular bladder wall thickening with avid enhancement, so not very tricky. Here is a case that started off with ultrasound in which we see this echogenic mass with internal vascularity, so obviously concerned about cancer. And here is the same patient with the arterial phase and the delayed phase. And I really like that we take the arterial phase down to include the bladder because often on the delayed phase, the contrast opacified urine doesn't really fill the whole bladder, so it can be actually a little bit hard to see these masses. But on the arterial phase, because they avidly enhance, it's much more obvious. This is a patient who came in with gross hematuria, and on CT, it's hard to see anything. And this is where MRI is also helpful, in that MRI has better tissue contrast, so you can really see the enhancing bladder tumors apart from the big hematoma. So they serve complementary roles in the workup of hematuria. So in summary, we've gone through these common causes for hematuria, and not talking about the renal parenchymal disease, but all these different things that can cause hematuria. So in conclusion, gross hematuria is associated with higher risk of malignancy than microscopic hematuria, and the CT is the study of choice in the detection of urinary tract stones. CTU and MRU allow for more thorough assessment of inflammatory and neoplastic processes in the urinary tract, and they are the exam of choice in patients presenting with gross hematuria or patients who are at high risk. Thank you very much.